From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello, and welcome to this author interview from the JAMA Network. This is Dr. Adamson, the web editor for JAMA Dermatology. Qualitative research is an area of research in which non-numerical data, such as text, video, and audio, are used to understand patient experiences, attitudes, behaviors, and beliefs. It's an important type of research that may be well suited for dermatologists who care for patients with diseases whose impact may be harder to measure numerically. In a new study in JAMA Dermatology, authors aim to assess current approaches to qualitative dermatologic research and the publication trends of these studies over time. Dr. Lucinda Kohn is an assistant professor in the Division of Pediatric Dermatology in the Department of Dermatology at the University of Colorado School of Medicine. She is the senior author and corresponding author of this new study, and she's here to discuss the findings and the potential implications of this work. Welcome to the podcast, Dr. Kohn.
Thanks, Dr. Adamson. I'm honored to be here.
All right. And I hear that you also listen to the podcast, so I'm really excited that we also have a researcher and listener of the JAMA Dermatology podcast with us.
Yeah, it's a great podcast. It's helped me learn more about dermatology research and what JAMA Derm's publishing.
For those that might not be aware of the research that you do or what your clinical focus is, do you mind telling the audience what you do at the University of Colorado?
Yeah, so my time is split between research and clinical care. I spend about 75% of my time doing research and only 25% of my time taking care of patients in our clinics and in our hospital. I'm housed in the Department of Dermatology at the University of Colorado, like you mentioned, but I'm also a faculty member in the Centers for American Indian and Alaska Native Health in the Colorado School of Public Health. And the way I got into my work is actually a winding journey. I got into this work because my husband is American Indian. He is a member of the Crow tribe in Montana, and he grew up on the reservation. And when I was applying for jobs at the end of my pediatric dermatology fellowship, I really wanted a job that worked with American Indians. And I found through multiple interviews that there was no healthcare organization or university ranging along the Rocky Mountains that had an explicit way of serving their nearby American Indian communities. So then I met up with my mentor, Spiro Manson, who is the director of the centers, and he said that he would help me build something through research. So right now my research is centered around increasing access to dermatology clinics for populations that are historically marginalized with a focus on American Indians. And I use community engagement and implementation science along with different methodologies like qualitative research, survey science, and database analysis to answer my questions on how to build a sustainable, ethical, and effective program.
It is kind of interesting how our interactions with people, whether they're colleagues, loved ones, etc., really do help us kind of chart a course for where we end up and what we end up studying.
Yeah, for sure. I mean, it's the heart and the motivation behind what I do is my husband's family. And when I see them lacking healthcare, I mean, I obviously give them care for myself, but I would love it for a healthcare system to do the same.
And do you also have a clinical focus, a disease-specific focus, or are your clinics more general dermatology?
My clinics themselves are pretty general. So, they're pediatric dermatology. So I see kids and adults under 21 usually. And we do see a lot of eczema and acne just because that's what's common. But we also do see a lot of rare things like genetic dermatoses and inflammatory disorders as well.
So let's shift gears to talking about this review that is being published in JAMA Dermatology. Looking at qualitative research from a sort of 30,000-foot view, why did you feel it was important to study this topic and perform a scoping review to make assessments about qualitative research in dermatology? Do you think there was a need there?
I do. I started doing qualitative research as a part of a research project that I was doing that was funded through the Society for Pediatric Dermatology. And this project was an implementation science study, and it taught primary care providers at a rural Indian health service medical center how to manage severe acne. And a part of the work was doing baseline qualitative interviews to gauge their needs and their practice habits and to tailor our intervention and curriculum to them specifically. And so we were collaborating with one of my co-authors, Megan Morris, who is a qualitative methodologist on our campus. And the question came up of how often do dermatologists use qualitative methodologies? And I am most a quantitatively trained physician scientist, so qual to me was very new at the time. And so this prompted us to do a brief lit review to find other qual studies in derm, and it ended up being this scoping review that we published. I had to give props to Micah Pasquale, our medical student who I was working with. She was the one who really took this question that both Megan and I had and made it into the scoping review that you now see.
And so you did a scoping review in which you plugged in dermatology and qualitative, the terms dermatology, and as well as 7 qualitative methodologic terms into PubMed and the CINAHL Plus database. And you got back almost 1,400 articles, and about 250 met your inclusion criteria. What were the overall results in the terms of the types of qualitative methodologies that you found that were used in dermatology? Were there some that were used more than others?
Yeah, so one of the major results that we found is that qualitative studies are on the rise. In the 1990s, there were only 2 qualitative studies that were published, but since 2010, there have been over 200 qualitative studies that have been published. So that's really exciting to know that qualitative studies are rising in popularity amongst researchers and amongst journals as well. The top qualitative methodologies that we found used by dermatology researchers were content analysis and grounded theory, although a lot of articles did not actually report their methodology. And think of qualitative methodologies as sort of the guiding theory behind the qualitative study that you're doing. So it's the approach that you use and the theory behind how you approach the data.
For those in the listening audience that might not be familiar with qualitative methodologies, could you explain one or two of them just so they have a sense of what you mean by content analysis as an example, or grounded theory as an example, or any of the other methodologic types that you looked at in your work?
Yeah, so content analysis and grounded theory were the 2 most commonly reported methodologies that were being used. And I'll just throw in a third. Ethnography is another fun one to know about. And they kind of exist on a spectrum. So content analysis is understanding a subject through interpretation of text data, and the text that you interpret is already made. So that this text would be things like clinic notes, tweets on Twitter, online forums, product or practice reviews. One question that content analysis study might ask is, what are the experiences and reactions of customers using a new product? And content analysis doesn't really focus on the context. You're already analyzing text that's pre-made, so you don't get to ask questions like, "Oh, what was the rationale behind what you did?" or "Why did you come up with what you're saying in your product review?" You don't have that context from your participants or from your text data. Ethnography, on the other hand, it originated in the field of anthropology, and it's not used very common because it's very time and energy intensive, but it's when you basically put your researcher into the context or into the environment that they're wanting to study. So, for example, if you had a question about how people in clinic make decisions, and it's about how the provider and the medical staff interact in their decision-making process. Like, for example, I'm just making this up. Maybe it'd be prior auths. Like, how does a prior auth get routed through a clinic setting, and how do we make it more efficient? Then you might want to have a researcher standing in clinic and observing how the entire team interacted with each other and making notes of the layout of the clinical setting as well. And in the middle is grounded theory. So grounded theory originated in the field of sociology, and it's aimed at developing a theory about a phenomenon like a social process that's being studied. Grounded theory is probably the most common approach used in the medical sciences, and it's the main method that I use. And granite theory integrates both context and the viewpoints of the people that you're studying. So one example of a granite theory question might be, how do primary care providers make decisions on acne management?
So, were you surprised at the different types of qualitative methodologies that were used? And the fact that many actually didn't report their methodologies. Was that something that you found a surprise?
A little bit, I guess. I think qualitative research is very new in dermatology, and so it's possible that our researchers are still learning to do it. And also our reviewers and journal editors are still learning how to report it well. One thing that did surprise me was that almost half of the qualitative research that we found were actually published in non-dermatology journals. They were published in more sociology journals, and that's probably because that's where the researchers are typically housed.
Why do you think dermatology as a field is just now starting to perhaps embrace qualitative research a bit more? Do you think that this is something that's unique to dermatology, or is this maybe something that in medicine in general is now becoming more appreciated?
Yeah, I think it's the reflection of medicine and health services research in general. Initially, we really wanted our results to be generalizable, which is what quantitative research is for. Qualitative research doesn't really care about generalizability as much as it does about context. And so, as our science gets better and we want to know why certain findings are not applicable to certain populations, that's where qualitative research might take a better role.
Do you think qualitative research in dermatology is something that may be uniquely useful because so many of the disorders that we take care of don't necessarily have an easily measurable numeric outcome like an A1C or a target blood pressure, right? They're things that are a bit less easy to quantify, like say itch or the amount of skin affected for psoriasis or atopic dermatitis. Do you have any thoughts on that?
I actually think that there is value to quantitative research, and quantitative research can help us place number scales and numerical data on outcomes. The value of qualitative research actually lies in its power to generate a hypothesis, and the quantitative research seeks to test. So, for example, qualitative research asks why, and it asks why behind the numerical data generated by the quantitative research. So, quantitative research, for example, is very hypothesis driven. And these hypotheses are typically formed by the investigator or a scientist that's leading the study, versus qualitative research typically goes in with an open slate and asks, what are the problems? What's happening? So, for example, questions that you can ask through qualitative research are, what is the lived experience of a patient with a disease? Or why is this phenomenon happening in a healthcare system? And one of the most common questions I like to ask in qualitative research is, what are the barriers and facilitators a patient encounters when accessing a medical service? Or what is someone's knowledge, attitudes, and beliefs towards an intervention? Because I really care about intervention adoption.
I think that's well said. And if you think about health disparities research, especially, we document disparities in, just about every major illness in dermatology as well as outside of dermatology as it relates to, race, socioeconomic status, sexual minority status. But just documenting those numerically doesn't necessarily get as to why. Why is it that, patients of certain races, ethnicities, or insurance types don't get their surgery for their melanoma in a expeditious fashion, or they don't get access to a certain biologic, or they don't have treatment that is guideline concordant? You can measure the fact that that phenomena is happening, but understanding why it happens often requires you talking to patients, maybe embedding yourselves in their healthcare journey, or some kind of qualitative methodology that can actually get to the why that you were explaining.
Yeah, absolutely. And you touched on this, but I think one huge value of qualitative research is that it can add value and amplify the voices of people from marginalized communities. So, people from marginalized communities are typically the minority in a large healthcare database or in clinical trials. And the field of dermatology, as we know, is not as diverse as it should be. And so our physician scientists and leaders may be unfamiliar with the lived experiences of people from cultures and backgrounds different from their own. And so qualitative research can really serve to amplify those voices.
Yeah, I would say that that's definitely the case. And even for certain disorders that we treat on a routine basis, we as dermatologists may not really know what it is to have really bad psoriasis, right? Because it's not a diagnosis that we might necessarily have. And so, really listening to the voices of patients may be able to help us treat our patients much better.
Yeah, I definitely agree. I think also something that people don't think about with qualitative research is that it can help guide policy development. So, qualitative research, it generates stories and it helps understand the context in a complex system that might not be easily quantifiable. And so, this is invaluable for advocating for a population, especially with policymakers and leadership. And it really illustrates what's going on with our patients. So, one example of that is the Society for Pediatric Dermatology is actually testifying to the FDA in a few weeks on iPledge, our Risks Evaluation Management Strategies program that manages isotretinoin. So, the Society for Pediatric Dermatology is collecting stories from providers on the challenges iPledge poses to our patients. And these examples and stories can be more illustrative than the data that's already published, which is more numbers. It's more approachable to policymakers to hear the individual stories of people.
If there's one thing that I've learned as a researcher is the power of stories. And you really can get a lot of powerful stories through the use of certain qualitative research techniques.
Yeah, I completely agree. I often start out my grant applications with a story, a patient story, because it just conveys the whole message of why we do the research we do.
Well, I want to thank you, Dr. Kohn, for this enlightening discussion. This is Dr. Adamson, web editor for JAMA Dermatology. To follow this and other JAMA Network podcasts, please visit us at jamanetworkaudio.com. This episode was produced by Daniel Morrow at the JAMA Network. The audio team here also includes Shelly Steffens, Lisa Harden, Audrey Foreman, Mary Lynn Ferkaluk, Hannah Park, and Dr. Linda Brubaker, Senior Editor, Multimedia. Thank you for listening. Catch you on the next episode of the JAMA Dermatology Podcast.